Hello, everybody. Welcome to today's event. We are so excited to have each of you with us today as we wrap up this three-part Catalyst for Change webinar series. I believe you can see my screen now, but we are so excited to have each of you join us. This event is co-hosted between the Foundation for Healthcare Quality, Washington Health Alliance, and Comagine Health. Before we jump in, we just want to review some items with you. You've been placed on mute upon entering the webinar. And you will also notice at the bottom of your screen, there should be a Q&A box. Please write any questions you may have for our presenters in that Q&A box at the bottom of your screen. We will not be calling on individuals to verbally pose their questions or comments to our speakers, but we will be reviewing the questions in the Q&A box, and our staff will be reviewing them to ask our speakers on your behalf. The webinar today will be recorded, and we do plan to send out a slide deck and the recording of this event via email to those who signed up to attend today's event. It will also be posted on our webpage. For our agenda, we will start with our introductions from our host organizations. We'll then jump into the presentations from our lovely speakers. Our speakers have been asked to highlight how their organization has worked to navigate barriers to sustain change to promote health equity within their work. We tend to ask one question to each speaker after their presentation. So again, when you place those questions in the Q&A box, we will plan to review those to present those to our speakers. But we will also have a large group discussion at the end of everyone's presentations, and we'll facilitate a discussion on the materials presented today and how we can create this sustainable work environment and commitment to health equity. There will be an opportunity again to ask more questions there. And then we'll wrap up the event and close it up. So as we begin, we'd just like to take a moment to bring Ginny Weir, Dr. Drew Oliveira, and Dr. Emily Transu forward to share their work from their organizations on what they're doing on health equity. So I'll pass it off to Ginny.
Thank you, Emily. And welcome, everyone. I'm Ginny Weir, CEO of the Foundation for Healthcare Quality. And I wanted to just root my comments in an equity why. If I was a birder, this would be my spark bird, also a recent This American Life podcast. Really what brings people into the birding world. My wife is a birder, and this is a hobby. I'm glad she has other people to talk to because it is not my thing. So really my equity spark has changed over time. When I was young, it was really this pure rage at the idea of people being treated differently, shifting over time to a wanting to strengthen my LGBTQ community, and now really expanded to focus on a future that allows my two girls to be whomever they want to be, whomever they turn out to be. So at the Foundation, I want to highlight our ongoing health-related social need and health equity convening, our work here to really build a community standard for our region. Our steering committee and our work groups have developed guidelines for advancing equity, social needs screening, social need interventions, and then storing and sharing data across sectors. And kind of as a culmination of all of this, we'll be hosting a social need and health equity summit on Thursday, November 7th. From 9 to 15 past noon. So please join us on that date to hear from Professor Edwin Lindo and others who are really dedicated to pushing forward a more equitable Pacific Northwest. And Emily will have more information about that later. Now I'm going to turn it over to Emily Transu.
Thanks so much, Ginny. Boy, that's hard to follow, and I'm sort of wanting to think about my own spark birds now as well. I'm the Chief Clinical Officer at Comagine Health, which is as many of you know, a national nonprofit healthcare contractor and consulting firm. Our mission is really, together with our partners, to work to improve health and create a better healthcare system so that people and communities will flourish. And I think that health equity is inseparable from that. Flourishing is about equity. You can't have flourishing in the same way you can't have quality without truly paying attention to equity. And you'll hear more about our efforts later in the webinar from some of our staff. But one of the things I wanted to call out that we've been thinking about a lot recently is kind of the intersection between our internal efforts around diversity, equity, and inclusion, and our more externally facing efforts around equity, which I think are often thought about as two two separate things, and we're really thinking about how those are very much the same thing, that the work that we do in the world is reflective of and reflected by the people that we have internally, and that in many ways these are sides of a coin and part of the same set of efforts. So I'm really excited to see some more conversation around that today. And I will hand over to Drew.
I think Drew's actually last minute
Oh,
unable to join us today, so I was going to invite
I'm sorry.
Denise to see if Denise would like to make a few comments.
Hello, everyone. Drew's actually trying to, he's in, if you could allow him to talk.
Sorry, folks, I was having trouble getting in, but thanks for having us. I think I missed the other introduction, so apologize for that. This is clearly an important area that we want to continue to dive a little bit deeper in. So really interested to listen to the panelists, to be able to use data to support some of the activities that we're seeing in terms of the impact of where people live on quality, access, avoidance, costs, et cetera. So I'll keep it brief and stop there.
Emily, you're on mute.
Thank you. We just want to take a moment to introduce our speakers to all of you. So we will hear today from Dr. Michael Mint, the Chief Population Health Officer from University of Washington Medicine. We'll hear from Kayla Salazar Ponce, the Director of Health Equity and Quality at the Community Health Plan of Washington. We'll hear from Dr. Ashby Wolf, the Regional Chief Medical Officer for the Center for Medicare and Medicaid Services, Region 10. And we'll also hear from Joanna Dehan, the Director of Community Health from Comagine Health. So our first speaker will be Dr. Mint, so I'll invite him forward.
Hello, can you hear me okay? Oh. Can you hear me okay?
Yes, we can hear you.
Oh, okay, great. Well, I'm Mike Mint. I have the privilege of serving, and sorry, there's a little background noise here. The phone is going off. It'll stop in just a second here. But I have the privilege of serving as Chief Population Health Officer of UW Medicine for the last 2 years. And in that role, where we look at how we both pay for the healthcare that we deliver, how we partner for the healthcare we deliver, and then how we actually deliver that healthcare. So I really feel that this is such an important and critical topic for our current healthcare environment, especially in the peri-COVID period, which I'll demonstrate here in just a little bit. So let's go ahead and jump in. And I have a brief comments, and I really look forward to the conversation later. UW Medicine, we're really rooted in our mission, vision, and values. And I'll just say that, as all of the prior speakers introducing us introducing this topic have said, it's really around how to improve the health of the public. That's UW Medicine's mission. And we advance that through our vision to have a care experience for patients and their families, help them achieve their personal goals for wellness and disease management, an educational environment as an academic medical center for health professionals, students, trainees, prepare them for leadership in professional careers, and then a research enterprise where we actually study this and do that in ways that can help promote the next generation and the next wave that we look at these important topics. And we always core based on our values. People expect compassion. Importantly, we embrace diversity, equity, and inclusion. We encourage collaboration and teamwork. We promote innovation, and we expect excellence. I will talk a little bit more about DEI versus health equity. And though Emily Transu really called it out importantly, that the more we can bridge those, the better, I will actually make a little bit of a pitch to make sure that we understand where initiatives to support these things might be different and might run in parallel, although I completely agree with her that these things are intimately connected. Next slide, please. What I would say, just to describe UW Medicine, is that UW Medicine is a very large and complex enterprise. Am I not seeing the slide move forward, or? Oh, thank you. UW Medicine, just to describe, is a very complex organization as an academic medical center with lots of parts and pieces that really work hard together to meet this inner purple circle of clinically integrated parts of UW Medicine. And then we have lots of partnerships, both in the community and then more broadly across the Wyoming, Montana, Alaska, Idaho state, the WWAMI states, where we are involved in both the education, some partnerships in regards to healthcare delivery, which I'll describe a little bit in regards to its impact and equity, as well as other local partnerships. Trying to organize this, I think, is a little bit of a microcosm for what we're all trying to do together. And what I'll posit is that health equity cannot be driven by any one entity, even an entity as large as Medicare, although, of course, I'll defer to my CMS colleagues to discuss that further. But it's really going to be thoughtful, long-term partnerships across not only our internal UW Medicine, but more importantly, across all of the agencies here and well beyond. Next slide, please. Why is this so important? I think that there's very demonstrable places. And one of the things, and I'll update this in the very next slide here, but when we looked at the impact of COVID, what COVID really did was sort of call out this growing weakness that we've had. This graph shows from 1980 to 2021 life expectancy in the US and then the OECD countries, other economically developed countries. And just comparing our red line spark to that gray average of the OECD countries, you can see that since the 1980s, we've been sort of in the US continuing to trail behind these other economically developed countries. But what COVID did certainly affected these other economically developed countries in a pretty significant way. But you can see that not only did it affect the US in that way, but it continued to drop pretty significantly in something that I think we can all agree is an important metric. Of course, not the only metric, but life expectancy. If we look in the next year, so actually let's go forward one, and it should appear on top. So this is actually the sort of the next year in the study to 2022. You could see that the United States recovered, but this is a Kaiser Family Foundation, based on a Kaiser Family Foundation article, and it shows that we've lost nearly 2 decades of progress in life still, even despite this rebound. And importantly for health equity, next slide please, this drop has not affected all groups. This is back to the 2021 data where this particular evaluation looked between racial and ethnic groups here. And I'll point to the left here with the big red numbers. This is where health equity can get lost in averages. The average US citizen in this lost 2.7 years, significant by any measure, but very inequitably experienced by different racial and ethnic groups. For whiter Caucasian populations or Asian populations, the drop was 2.4 or 2.1 years, so less than that of the average. But pretty significantly, if you're Black or African American or Hispanic, the loss was about 4 years or a little over 4 years. And if you were American Indian or Alaskan Native, the loss was 6.6 years of life. Just a pause, 6.6 years of life that affected quite differently across all of these different groups. And if you look at the top 10 causes of death across these groups, they're quite different across many of these. It was emphasizing this homicide being the number 7 cause of death in Black and African American individuals, especially for males, and how that's not even in the top 10 on any of the other groups here. So very inequitable. And really, I think COVID just called out some of the fundamental weaknesses we have in the United States on delivering equitable healthcare. Next slide, please. At the UW, we've updated post-COVID our healthcare equity blueprint. And really, it's a long-term comprehensive strategy with these pillars: leadership and strategic operations. How do we bake this into everything we do? How do we develop a diverse and equitable workforce across UW Medicine's enterprise that reflects the communities we serve, informs the care we give to the communities we serve, and can continue to serve in partnership with the communities we serve in this community engagement model that we going forward. We're going to continue to do research and evaluation as an academic medical center on what we're learning and what works and what doesn't work, as well as looking at individual programs. And I'll describe one of those later in this presentation around quality improvement and how do we use the rigor of a quality improvement program around building in and sustaining better health equity. And then creating learning environments where we can continue to engage our learners and teachers going forward in regards to continuing to forward this based on this research and evaluation. So this is an ongoing long-term blueprint that we're using at UW Medicine to move forward our equity plans. Next slide, please. I'm going to focus in on just one of the projects that we have ongoing. And over the last 2 years, we've really focused on improving breast cancer screening as we identify that especially Black and African American women not only are screened at a much lower rate, but die at a much higher rate from breast cancer, even if detected early, but especially because many cases are detected later. So we did a very an ongoing work right now in regards to improving screening. And these are the spark lines over the last year. And I have 4 circles here. I'll first focus on the second circle down below, where you can see that in Black and African American women, our screening rate was 57.6% at the beginning of this, and then went up to 65%. That mirrors the 4th one here of improvements that we've had in our Caucasian populations or white Caucasian populations. We've done improvement work over across multiple populations. But we did have an emphasis on reaching out to Black and African American communities, making access more available through Namavan and other ways that we have going into communities with limited access or limited transportation and working with local healthcare agencies on this. I will say that we did not at this same time, outside of the broad improvements efforts, focus. And that's where I wanted to point out on the left, American Indian or Alaskan Natives, where the improvement was much, much less, as well as Pacific Islanders, where there was almost no change in this period and still much lower screening. What I wanted to point out in this slide is just that we can make improvements, for different groups using significant interventions and significant focus and energy and efforts, which are really important. But it's hard because not all of these cross over to all populations. And we are in the process of understanding then what are those drivers? How can we sustain a lot of these improvement efforts across all patients who are disadvantaged, and race and ethnicity just being one of many, including economic disadvantage or disabilities or other ways that any way we slice and dice this, many of patients who have limited economic resources or limited transportation resources or access have a real challenge in moving forward. And how do we do this broadly, and how do we sustain this over time? My last slide really is just high level. And my apologies, I think that this version of this was a little cut off. It wasn't the final version. That's a user error on my part of sending in my slide deck. But I'll just say that a couple of concluding thoughts from my perspective. One, and again, I alluded to this earlier, I think that there's a lot of move against DEI initiatives from an employer across a lot of industries, including many tech companies across the country here. And I would only say that the interventions that we do in regards to health equity, the care of wellness, and looking for inequities in health outcomes or health access are really important for us to look at, in addition to, but perhaps in ways that we can decouple from some of the politically charged areas around DEI initiatives for worker programs and employee programs. At UW, we do believe that these are intimately connected, and we support both of those. But I do think that when we reach out to the community, I want to make sure that I think, watching the political debates last night, that there's going to be different lenses of this for different groups of people who will need to be aligned to help support this work. Continued integration of health equity with all initiatives across mission-aligned healthcare organizations. Within UW Medicine, we use a health equity evaluation tool for all our major initiatives, where we look through all of the potential implications in regards to health equity for initiatives that we have going forward, whether they be financial, whether they be care related, so that we try to have a more holistic view and bake this into everything we do. I think that's going to be important. And again, I think these partnerships are important. Also, moving payment models towards more equitable models is key and critical. I think that we do have to acknowledge that fee-for-service payment models are inherently inequitable in the way they're done. And a predominantly employer-based model, especially traditional employer-based model, as opposed to independent folks working in different types of industries, including now a lot of the tech industries like Uber and other delivery services and other things. We have to start thinking about different models to sustain health equity from a core of how they're paid and how they're resourced to sustain these initiatives. I also think that changing the payment model is only one piece. We have to also change the care delivery models, which is much harder than I think most people appreciate in regards to longer term programs. For example, at UW Medicine, we have engaged through the state of Washington and CMMI, the innovation wing of CMS, in regards to making care primary, which starts to look at our traditional Medicare patients and looking at a longer term program, 10.5-year program with upfront investments to better build community connections, care management, care working, so that we have a long enough timeline to change and evolve our care models. I think it's critical to address primary care shortages across the country, especially in rural regions. And how do we align technology to better do this? And sorry, this is the part that was cut off. I just mentioned that with the primary care shortages that we have, things like remote patient monitoring, we have programs that we sponsor through UW Medicine, including Project ECHO, which try to bring expertise and office hours from clinical experts on issues like hepatitis C, on HIV, on complex disease management out into more rural communities to better support the care teams there. And then start thinking about different care delivery models, including virtual care models, and potentially even home-based models like hospital at home and others, using an equity lens to look at this. I think there's going to be a lot of opportunities for us in this space. And we really should start thinking about how technology can serve health equity and not just, sort of different kinds of initiatives sponsored by for-profit corporations, which again, nothing against those. It's just that I think that we need to have that health equity lens and sustainability behind a lot of the initiatives that will make meaningful change in health equity. So that's all I have, and I'll hand back to Dr. Sultan.
Thank you. So there was a question that came in the chat that we're hoping that you could briefly answer. One of the attendees asked, what was the time frame for your breast cancer screening initiative, and what strategies and tactics did UW Medicine implement per respective ethnic or racial groups?
So several interventions across 2 years, with the first part of it being more of a discovery period of trying to look at the upstream root causes of why the screening was lower. We also have similar work going on in regards to survivorship and access to treatment. So just that those two are related but separate. The slide I just showed you was in regards to screening. Several interventions, and what I'll say is that it's an ongoing project that we've been doing with the intervention piece about 1.5 years into it. What I would say is that we've done very specific outreach to Black and African American communities, and we've identified even subgroups of population, including different geographic areas like Somali-speaking communities. We did outreach to community centers and community health workers that work within different communities that we've seen were in the under-screened group of Black and African American women. And then we did look geographically at increased access through MammaVan and other access resources to try and bring screening resources closer to communities that had more limited access to healthcare facilities for screening, as well as pretty significant access problems we're having all across the board. In other words, even just regardless of race, ethnicity, or insurance, it's just challenging sometimes to be able to make an appointment in many of our healthcare facilities. So what we did was we created dedicated space and time for these MammaVans to go out to communities, did the advertising and access and scheduling within different communities that we identify as limited access communities, and try to build capacity in those areas using these type of mobile resources. We're also in the process of thinking about how to better do fixed resources And that's where some of our partnerships can and should come into this program in the longer term. In other words, partnering with more local healthcare organizations. This could be an FQHC or others, or other clinical systems that are in our space. We've had conversations, for example, with the Providence system around exploring how we might be able to co-sustain different types of centers that may not make sense for any one healthcare organization in the current payment models, but may make sense for partnerships across broad groups of healthcare delivery organizations. That's just a bit of sampling. There's a lot of unique ways that we reached out in different languages and different, again, community-based models, but certainly happy to chat with you and connect you with the teams that have been leading this for the speaker if you just want to reach out to me after this conversation.
Thank you so much. We really appreciate that. We'll now transition to our next speaker. So I'll invite Kayla Salazar-Ponset from Community Health Plan of Washington forward.
Hello, everyone. Thanks so much for having me today. Grateful to be here with you all. I'm Kayla Salazar-Ponce. I'm the Director of Health Equity and Quality. I use she, her pronouns. And Jenny, I was really inspired by your question about your health equity spark, and I'll share mine as being a third-generation Mexican-American and seeing my grandmother who had not only low English proficiency, but also low literacy levels navigating the healthcare system, especially in her final days. So always think about that when we're talking about health equity. I'm going to start actually today by making a little bit of an assumption. My assumption is that everyone is really interested in how we actually figure out how to reduce those disparities in care. And it's a really difficult thing to answer. And I've searched for that simple answer for so long. And I wish I had a good one for you today, but I don't. What I can share is how we have tried to use one really important program at Community Health Plan of Washington to really build a strong infrastructure to be able to advance health equity across our network. So if we move to the next slide, I'll dive right in. Thank you so much. So CHW was founded in 1992 by community health centers across the state as the only local not-for-profit plan in the state. We continue to be governed by those 21 CHCs today who make up the majority of our primary care network. We provide care to approximately 300,000 Washingtonians across the state under Medicaid, Medicare, and an exchange product. Because our goal was always to support underserved communities and those CHCs, we really do believe that health equity is in our DNA. But before I really start talking about this program, I have to share a little bit about the journey that I think helped set us up for success and even launching a program like this. And one of those successes is really focusing in on NCQA's, what was previously called the Multicultural Healthcare Distinction Standards and has since been rebranded as the Health Equity Accreditation. It's a framework about how you really set up a long-term sustainable kind of health equity organization. And I really encourage folks to look into it if you haven't already, as it's meant for not just managed care plans like CHPW, but other healthcare organizations as well. So we began working on that program back in 2016, and there's a lot that goes into that, including setting up your data, reporting, and all of that. But at the same time, we also had just made a commitment to making health equity what we do as an organization. And so around the 2019 period, we started participating in a number of national learning collaboratives that were also focused on not just health equity, but also what do you do for yourself as an organization to really consider DEI work? And this, of course, was right before the pandemic when that increase, urgent sense of urgency around addressing DEI happened due to the murder of George Floyd and all of the racial unrest in our country. So it was really a great time for us to participate and kind of push ourselves forward and really accelerated, I would say, our commitment to health equity. We then, in 2021, to kind of solidify that commitment, created our overarching strategic plan to be the leader in the pursuit of whole person care and health equity. And that wasn't just in writing. We also had initiatives that tied back to that just to piggyback on what Mike said earlier, we had initiatives very specific to health equity. And we also had initiatives very specific to our internal DEI culture and what we were doing to be better as an organization ourselves and create a more equitable work environment. One of the other things that we did out of that strategic plan was decide that we were going to set a list of accountable measures that we wanted to see improvements in. So for the very first time in 2022, we decided to release a health disparities report that identified 8 priority measures of focus. The primary reason for this is because we need to hold ourselves accountable to actually showing a reduction in disparities over time. And so we said, here's our measures that we're going to focus on. we're going to do our best to put as many initiatives forward to actually drive improvement in these measures. And I'll just note, since then, we've also received that new health equity accreditation from NCQA last year. And go to the next slide. So again, that's just a little context, and to share, I won't go into the details of the report, and we're working on getting it made publicly available right now for you all to look at. But I'll just share kind of a little bit of a review of the measures. So we've got kind of prenatal, postpartum care, well child visits. We've got a lot of preventive screenings, including some very important cancer screenings. We've got some chronic condition measures, including A1C and blood pressure control. And then we also have the follow-up after hospitalization for mental illness to recognize the importance of integration in our state. You can go to the next slide. So now I'll get a little bit more into the program. So like I mentioned, we started participating in these national learning collaboratives, and one of those was actually the Advancing Health Equity, Leading Care, Payment, and Systems Transformation Learning Collaborative that's hosted by the University of Chicago. And it's actually a very unique program in that it asks us to partner as a managed care plan with the state Medicaid agency. So that, of course, is the Washington Healthcare Authority, and also a provider partner. So we chose to actually bring in all of our 21 FQHCs as Community Health Network of Washington, that network of CHCs that make up our primary care unit. And this learning collaborative challenged us to do two really important things. One, it says you need to focus on building a culture of equity within your respective organizations, and doing that also together collaboratively. But the other thing it asked us to do was to create an alternative payment model and care delivery transformation projects. Now, a lot of the other states chose to focus with one very singular provider, like maybe a hospital, and on one very specific topic, like maybe diabetes or something along those lines. We were a little bit ambitious and said we wanted to actually try to drive this work across our entire network of CHCs. And so we decided to create a learning collaborative within a learning collaborative. And as a part of that, we have provided $50,000 annually to all 21 of those FQHCs across the state as upfront capacity building funds to advance equity in whatever they believed was essential for them to build that foundation. And that funding was made available in 2021, 2022, and 2023. It actually is also available today, but I'll talk about that in a minute. And it was pulled up as a part of our existing quality incentive pay for performance money. So it's really made, again, available upfront. The other component of this learning collaborative is that we also asked those participants to join us in a couple of other opportunities. So one was we paired them with like-minded CHCs who are working on similar projects through a peer-to-peer kind of cohort structure where they met every other month. We also provided a very robust learning series where we'd bring in experts from across the nation on various topics to actually build up a common knowledge around health equity and almost create a common language about how we talk about health equity and really give some of those best practice dissemination. I've shared just a couple of the example cohorts here on the right. So you can see we've had some folks who are focused on child maternal health, internal DEI, building out things like equity councils or other infrastructure, chronic condition management, certainly folks that had really specific health disparities that they were looking to work on. Some folks who were working on patient experience work, just making sure the overall experience of their patients was better and more equitable. And then a lot of folks choosing to focus on social drivers of health and really building in how they address social needs as a part of their health equity strategy. If we can move to the next slide. Just to share a couple of outcomes from this process. So again, we ended up having anywhere from 14 to 19 CHCs participate in a given year. So there's been a lot of projects, I think something like 40 over the course of the life of this first 3 years of the program. But here's a few specific examples. So one CHC actually used the funding to break ground on a health and hygiene center to support those experiencing homelessness. Another developed a couplet visit for mothers and babies to both improve that postpartum visit, since moms are so often left out, and also reduce disparities in care that they had noted. Another actually implemented their own equity council and even ensured that there were equity budgets for all of their clinics across their network. Another increased depression screening rates from 20.7% all the way to 54.5%, and actually very specifically focused on a disparity. So this is just a reminder that working on a disparity in care can actually usually lead to improvements across your entire patient population. Another rural clinic hired a patient navigator that assisted in at least 20 patients per week on addressing their SDOH social related needs. And I'll just share another quote from one of our participants who has participated since the very beginning of this project. They said that our CHC would not be where we are in our equity journey had we not had the flexibility, funding, and equity capacity building that this program allowed for. We'll move to the next slide. So I just want to kind of highlight the lessons learned from this experience. I think the first and foremost is that we really needed to spend time on the culture of equity piece. We had to have those learnings and those tough conversations as a group to really drive us toward actually being ready to implement health disparities work and to do it in a very authentic way. We also, again, had experts coming in to share different learnings, and it just really helped create a boost of energy and also knowledge growth. The other thing that was so essential was the way that we provided this funding. It was incredibly flexible, and as I mentioned, it was upfront capacity funds, so people could really decide what did they actually need to use that funding for, what was going to be the most important to accelerate their health equity journey or ability to work on health equity at their clinic. The last piece that about, just being really transparent, we had such a hard time designing a payment model for 21 very different community health centers, some whose quality teams consist of a single, provider who's setting in that role in addition to their patient loads, some that have full quality improvement teams. So just very different, needs and also socially different as well. And so we really needed to come up with a solution that that met everybody's need, that had some flexibility built in, and that also had plenty of time to bring folks along on this journey. We wanted to recognize that everybody's at a different place and has different resources to do this work, and build a process that was equitable for all of our community health centers as well. We'll go to the next slide. And I think this will share a little bit about where we're going. So as I mentioned, this has been going on the last 3 years, and we're actually in a process of rebranding this program to kind of signify a transition that we're doing. So over the next 3 years, our goal is actually to start incentivizing the reduction of disparities in care in those 8 measures that I mentioned earlier. So right now, we are having all of the CHCs complete a cultural responsiveness assessment to understand if they're ready for that. And if not, what can we do to actually help support them in getting there? At the end of this year, they will have selected one of those 8 measures to actually focus on. And then next year, they will use the funds that we're still providing today for capacity building to actually build out a very specific disparity intervention to address that measure that they've decided to focus on. And then in 2026, they've been given at least a year and a half at that point to actually focus on the disparities reduction. We will begin incentivizing, giving extra payment to those that are able to make improvement. And I want to be clear, not reduce entirely, not get rid of, but make improvement in the reduction of those disparities through that existing pay for performance program. So that's what I have for you today. I'll just wrap up by saying, we hope that this program articulates many things, but one, that you have to give folks time. You can't expect folks to get rid of a disparity that has been made over the course of centuries, and also support people, make sure that you're participating and providing that upfront capacity funding as well.
Thank you so much, Kayla. When you and I were talking about this presentation, we were talking about those 8 measures that you identified earlier, and we're just kind of discussing, and I'm hoping you can explain a little more. Can you explain the process in which CHPW took to prioritize which accountability metrics to focus on without feeling like you may be deprioritizing other important health metrics? Because there's so many things going on out there that we're seeing within our communities. I'm just kind of curious how you went about that process.
Yeah, we actually went through a very robust process that the Advancing Health Equity Learning Collaborative had kind of provided to us, called a priority matrix. And so we really laid out a ton of options. And ultimately, what we kind of landed on were a couple of things. So one, recognizing that we needed to align with state, local, and national priorities. So the health equity accreditation standards, or the previous multicultural healthcare, they provide a list of measures they ask plans to focus on or others to focus on. So we definitely included those. And then locally, we knew that there were other measures that were important to the state of Washington. So we looked at things like our value-based payment contracting, and just ensuring that we included kind of a mental health measure, because that is so important in our state. So it was a little bit of a process, and folks who, if there's anybody on the call who participated in that, it took us about a year actually to come up with those final list of measures. So I hope that's helpful.
That's great. Thank you so much. We'll now transition to our third speaker, so I'll invite Ashby Wolf forward to present.
Thanks so much. And it's a pleasure to be here with you and an honor to participate with my fellow panelists. I'm Ashby Wolf. I'm a family physician, and I am the Regional Chief Medical Officer for the Centers for Medicare and Medicaid Services. I'm actually based in Seattle, and among many other things, I also am the co-lead for the CMS Acute Hospital Care at Home initiative for the agency. And with the excellent information that's already been presented, I'm hoping to give you an overview of some of the ways in which CMS is actually sustaining our health equity work in a variety of ways. We're going to talk a little bit about the CMS National Quality Strategy and its emphasis on health equity. We're going to talk a little bit about some concrete examples of the way in which this strategy and our health equity work is manifesting across the different programmatic areas that our agency has authority over. We'll talk a little bit about the Innovation Center as well, which my fellow panelist Mike referenced earlier. And then I'll close with a couple of key examples of our reimbursement policies, specifically within Medicare, but not limited to Medicare, that is really helping to support reimbursement for clinicians' work in the health equity space. So with that, let's move to the next slide, and we'll talk a little bit about the National Quality Strategy first. And many of you are well aware that CMS has had a foot in the quality improvement world for many years, but in 2022, we took a step forward to kind of revision our quality strategy, which is presented via the link on this slide if you'd like to take a closer look. But really, this quality strategy is a long-term effort to promote high-quality outcomes of care and safe care for all individuals that are beneficiaries of our programs. And it's a really person-centered approach that looks at across the continuum of care. So from home and community-based services all the way through the acute care experience, post-acute, and across all of our payers. So traditional Medicare, Medicare Advantage, Medicaid, and the Children's Health Insurance Program, or CHIP, and Marketplace. And this strategy has also incorporated lessons learned from the COVID-19 public health emergency, as has also been referenced by my fellow panelists. That was a significant opportunity for learning for the agency, and really highlighted the urgent need to have CMS support transformation towards a more equitable healthcare system. And as you can see on this slide, the CMS National Quality Strategy has 4 priority areas, each with 2 goals. And specifically, there is one that is focused on equity, person-centered care, and engagement. And specifically, our work in this strategy is across the agency, and we manage that work across what we call strategic pillars, each of which is focused on a different aspect of our goals informed by the National Quality Strategy. And one of those 6 strategic pillars is specifically advancing health equity and addressing health disparities that underlie our health system. So I think it's pretty telling that CMS specifically is prioritizing its work across all of our programs around the health equity issues. And CMS defines health equity as the attainment of the highest level of health for all people, where everyone has a fair and just opportunity to attain their optimal health, regardless of race, ethnicity, disability, sexual orientation, gender identity, socioeconomic status, geography, preferred language, and other factors that affect care and access to healthcare and health outcomes. So we're really working on advancing health equity in 3 specific ways, again, informed by the goals in the National Quality Strategy. One is designing and implementing policies that support the health of all those that CMS serves. A second is working to eliminate avoidable differences in health outcomes that are experienced by people that are disadvantaged or otherwise underserved. And the third is providing the care and support to those who care for our beneficiaries so that our beneficiaries are able to thrive. Let's move to the next slide, and we'll talk about one specific example of this work in the maternal health space. The first I'd like to highlight is a report on rural maternal health equity that actually was published 2 years ago, but that came out of a few years of work of engaging with our beneficiaries, clinicians, and community members, identifying next steps and recommendations for the agency to move rural maternal health equity forward. And so those next steps and recommendations, a few of them are highlighted here, really identifying the fact that CMS is in a position to help support the dissemination of best practices for quality improvement related to maternal health. that we are also in a position to apply and summarize lessons learned during the public health emergency during COVID to promote innovative care delivery, including telehealth and service delivery. Another recommendation that came out of this work was to really focus on improving rural maternal health outcomes for women of color in their communities, and specifically aligning CMS work with broader priorities of the Department of Health and Human Services. And taking this work, it has manifested itself concretely in what's known as the Maternity Care Action Plan, which is really our coordinated effort to improve access to maternal health care and to improve health outcomes and reduce disparities for our underserved patient populations across the country. And in looking at our own programs, we've identified 5 gaps in our programs that we are working to address in order to support improved maternal health across the country. One of those gaps is with respect to coverage and access to care. And CMS is working to improve access to comprehensive health coverage, including in the postpartum space with our Medicaid programs and the Children's Health Insurance Program, to ensure that coverage actually provides meaningful access to a full range of health care before, during, and following pregnancy. Second, we're looking at our gaps in our data and ways that we can improve our data collection efforts to better stratify and identify disparities in care so that we can then address those issues. Third, we're looking at the quality of care, and we're working with states, clinicians, providers, and other key stakeholders to really improve the quality of care that beneficiaries receive, again, before, during, and after pregnancy. And couple that with a focus on workforce, collaborating with our states as well as our sister agencies like the Health Resources and Services Administration, or HRSA, in order to identify opportunities to expand access to a diverse maternal care workforce, including opportunities to develop our own payment policies around support for work that is done by peer navigators and community health workers. And then finally, the 5th gap that we've identified and that we're working on is related to social support and work to build connections between the clinical care community and social supports that are provided by other federal, state, and local partners in order to really provide that whole person wraparound care. Let's move to the next slide, and we'll talk about another concrete example that is within the Innovation Center. And so you heard Dr. Mint earlier reference Making Care Primary. That is one of the current models within the Center for Medicare and Medicaid Innovation, or CMMI, also known as the Innovation Center here at CMS. And of course, many of you are aware that the Innovation Center was created in the Affordable Care Act for the express purpose of developing and testing innovative payment models and innovative service delivery models within the programs over which we have authority. And the Innovation Center did its own version of revisiting its strategy a few years ago, and it manifests in our vision to support a health system that achieves equitable outcomes through high quality, affordable, person-centered care. And you'll notice the yellowish orange goal here under the strategic priorities is specifically calling out advancing health equity. So I'd like to talk a little bit about one of our models. You heard about Making Care Primary. We also have a Transforming Maternal Health model that has just gone live and who has an active open application until September 20th. But there's also a model that's related to the care of persons with dementia, and I want to speak a little bit to that one as well. This is the GUIDE model to which I'm referring. GUIDE is an acronym that stands for Guiding an Improved Dementia Experience. And the GUIDE model really is an example of our work both in the behavioral health and the health equity space to really test an innovative whole person care model of delivering that care to persons living with dementia. And as many of you are aware, people who live with dementia often have multiple other chronic conditions. They receive fragmented care, often have high rates of hospitalization and emergency department visits, and they often need 24/7 care. And the challenges of managing that care, providing consistent support, dealing with behavioral and psychological symptoms of dementia can present a significant mental, physical, emotional, and financial burden to family members and caregivers of those with dementia. And it significantly, disproportionately impacts Black, Hispanic, Asian Americans, Native Hawaiians, and Pacific Islander populations. And so the guide model was developed with that in mind to offer a standard approach to care, including 24/7 access to a support line, caregiver training, educational resources, and respite care, with the goal being that this standardized approach and additional resources to practices that are participating will ultimately allow people living with dementia to remain safely in their homes for longer by preventing or delaying nursing home placement, and also improve the quality of life, not only for those living with dementia, but for their family members and caregivers as well. And specifically, there are some aspects of work and health equity that are built into the model that I just want to call out. One of those is requiring participating practices to implement health-related social needs screenings and referrals, to leverage data that we are gaining from the model to identify disparities and then target improvement activities with those participating practices. And finally, there's a built-in health equity adjustment to the model's monthly care management payment to provide additional resources and incentivize practices to care for underserved beneficiaries in their community. So really interesting aspects to the work that the Innovation Center is doing now in the health equity space, just by way of an example. And we'll move to the next slide, and I'll just talk briefly about the last point I wanted to make in terms of how CMS is really baking in health equity into our reimbursement policies. And that's with respect to a number of different efforts, but the one I'm going to mention is within our Medicare physician fee schedule. Many of you are probably aware that the physician fee schedule is an annual regulation that we publish every fall that really sets the policy rates, reimbursement rates, and policy payments for the calendar year. And this calendar year, the physician fee schedule, not only does it outline the rate setting and payment rates for all of our services that we provide in Medicare, but also it includes policies that are aimed to advance health equity under Medicare Part B, provides for Part A and Part B payment for certain dental services, which can have a big impact on our disadvantaged and underserved populations. And it also expands access to behavioral health care services and focuses some specific policies on equitable care for our Medicare beneficiaries. Now, I could speak for a lot longer than the time I'm allotted on this regulation because of all of the different aspects of the work that is built into our regulations this year, but I'm going to highlight three particular examples very briefly. One is caregiver training services, the second, social determinants of health risk assessment, and then finally, community health integration. So very briefly, with respect to caregiver training services, CMS is going to be paying clinicians for the time that they take to train caregivers to support patients with certain conditions, such as dementia. So in other words, physicians, advanced practice providers, therapists, when they're working with a patient who has particular high-risk chronic conditions that needs additional assistance and caregiver support, the clinician's time that they're working with or educating or referring, coordinating referrals for that caregiver actually will be paid for under the physician fee schedule. When it comes to social determinants of health, it can really impact a patient's ability to adhere to a treatment plan and specifically can cause particular challenges for that patient. And so we have finalized payment policies for this year and beyond to recognize the time that clinicians are taking to spend time and resources assessing a patient's social risk and then taking the time to coordinate those referrals as well. So these social determinants of health risk assessments can be done as an additional element of a Medicare annual wellness visit, and that confers an additional payment to the clinician. And we've also finalized codes that will allow folks to do social risk screening during an evaluation and management or behavioral health visit. And then last but not least, you've heard each of the panelists mention coordinating with peer navigators and community health workers, and CMS has finalized specific coding and payment policies beginning this calendar year for monthly payments to clinicians that are involving and working with ancillary personnel such as peer navigators and community health workers when it comes to coordinating care for patients with high-risk conditions and multiple chronic conditions. So there's a lot to unpack there. I've mentioned a lot, but hopefully when you all have a chance to see these slides, you'll be able to click on the links that I've provided and see a little bit more detail. But really overall, CMS believes that these policies that I've mentioned, among others, will support the equity, inclusion, and access to care for our most vulnerable beneficiaries. So thank you so much.
Thank you so much, Ashby. During your presentation earlier, I was seeing about how you identified 5 key gaps in maternity care, which you were highlighting as you were speaking. And you were talking too in your presentation on the coverage and access to care piece. Can you highlight one action your office may be working towards to strengthen cover and access in care in rural areas, specifically as it may relate to maternity care deserts?
That's an excellent question, and something that is a high priority for CMS, given the number of facilities that we're seeing make decisions around closing an obstetrical service, labor and delivery ward, or otherwise. And this is something that CMS is particularly concerned about in collaboration with other agencies within the Department of Health and Human Services. One thing that we are particularly focused on is understanding where there are opportunities for us to support reimbursement for maternal health care in rural and frontier areas, understand where there might be opportunities for CMS to consider additional payment policies with respect to maternal health care. A lot of this is in the discussion phase, but it is an active part of the Maternity Action Care Plan. And so we've got some additional opportunities in the future to really work more closely on really evaluating where there might be opportunities for changing existing policies. None of that has happened yet, but it is a big concern for the agency. And one of the things that we're doing to really assess where we might best make future rulemaking is to actually get out to rural and frontier communities that are experiencing maternal health care deserts. And so each of the different CMS regional offices around the country, including the one based in Seattle, have been out to multiple frontier communities across the Pacific Northwest this year to speak with critical access hospitals, obstetrical service providers, and others, community members who are challenged by the immediate lack of access to maternal health care. And so better understanding our local colleagues and beneficiaries' experience will help CMS better understand how future rulemaking could really address some of those problems. So short answer is more to come, but certainly take a look at the Maternity Care Action Plan references that I mentioned, and happy to follow up with anyone who has additional questions there. Thank you.
Thank you so much, Ashby. We'll now invite our final speaker, Joanna DeHaan.
Awesome. Thanks, everyone, for sticking with us. I am going to approach this from the lens of how we at Comagine Health are weaving health equity into the lifespan of our initiatives. And so I'm the Director of Community Health, Joanna DeHaan, and I was based in Washington the last 15 years, just moved to Oregon, but happy to still work across many of our Western states. And I'm going to actually go ahead and skip about the next 3 slides, Emily, because I think Dr. Hrinzu has been able to share with you a little bit more of what we do at Comagine. And so I'm going to really focus on our community health service line specifically. We do have a DEIB advisory council and initiative that runs probably like a lot of other people's internally. And as Dr. Hrinzu said earlier, looking at how to continue to really link the internal efforts that we have with the external work that we're doing in the community. So on our community health team, we are really focused on improving clinical and community coordination and connections, and building capacity to support health and self-management outside of the walls of the traditional healthcare system. So we're really trying to figure out what's happening around where people live and work and play, and how can we better address their social needs to really prevent chronic disease, prevent avoidable encounters with the healthcare system, like many of you are doing as well. Next slide. And this slide just talks about our approach, and I'm actually going to skip over this because as I talk through the lifespan of the initiative, we will hit those areas. So So the way I organize this presentation, I think what's been impactful for me in my 2 years at Comagine is really thinking above and beyond just how my own learning about racism and health equity and the work that I am doing as an individual in my own bias, but also like how are we applying this really every single day? And so looking at these 5 areas of kind of how we have an initiative start at Comagine, our community health team, through how we sustain them. We're going to talk about some of the approaches we use in each of these areas while we try to really move at the speed of trust. Next slide. Okay, so our first 2 areas are proposal and discovery. And sometimes, you know, we're discovering what we want to do before a proposal or after. Sometimes proposals are very formal or informal. But I will say our big approach to health equity for me is really around the work that we do to team with our partners. It's crucial for us when we go, and whether we're going to a federal funder like the CDC or HRSA, or we're going to work collaboratively with the state health department, that we are going out to our partners and actively involving them in that process. That can include everything from partner meetings and role negotiation and co-creation to developing budgets so that we're planning to subcontract with them after award. That also goes to engaging partners in the community around input sessions, so that as we're developing a concept for what we, you know, think we want to bring to the community, we're creating the space to present that concept and seek feedback before we even put that, you know, idea out there into a proposal response, and really using that to tweak the concept and proposal based on the feedback that we are provided, matching that to the data that we're seeing, the analysis that we're doing in terms of where our priority populations are within a certain region or around a certain health condition. And I will say this all sounds easy, it's very much easier said than done, right? So easy to put the bullets on the screen, but hard to sometimes go and confront like what you're putting out there and what you think you want to do is not really the direction you need to head, and taking the time and resource to make that pivot from the very beginning. Next slide. So I'm going to share a couple examples of health equity approaches we've done in the discovery phase. And in this case, these discovery phases happened after we were awarded funds from our community. So I'm going to focus on community surveys and the human-centered design process. Go ahead. Next slide. Thank you. So in Washington State, we've been working in partnership with the Department of Health to work with the Black or African American community in 3 different regions around the state. And we were essentially doing this work using ARPA funds and CDC funds focused on COVID-19, but we're doing this in 23-24. So we are at the phase where people are a little bit fatigued around COVID and immunizations, but really still seeing that disparity in folks being immunized and hospitalizations and COVID rates. And so we decided to take a community health worker approach, and you'll notice that approach comes up in a lot of what I'm going to talk about in our different initiatives. I think we really view community health workers as trusted messengers who are just really well positioned to be connected to and advancing things in their community. And so we do a lot of work to support them. But in this discovery phase, we partnered to and distributed a Washington Community Health Concern Survey. We did this through social media and targeted all of our ads were culturally tailored to the Black and African American community. They were vetted by the community health workers that we worked with. They were presented through those organizations like local social media, and resulted in, for this question anyway, like what topics are most important to you, with some rich data around what was actually happening in the community, not what we assumed was happening. We know we need to address COVID-19, we see the data, but what are people actually experiencing on the ground? And so what this did is this helped us before we even launched into like training work with CHWs and their outreach in the community. It allowed them to actually like filter by zip code in their area and race to figure out what were people saying in their community, in their neighborhood, and then integrate and tie COVID efforts to those other areas of need. Next slide. Another approach we've been using recently is human-centered design. And a lot of us have talked about maternal health services today. So we're working in Nevada on an integrated maternal health services model. And at the very outset of that, you know, the approach that we wrote into our proposal with our partners was that we are going to use and train our staff in facilitating human-centered design, which is really a person-centered approach to designing services and systems and products. And I think it doesn't get used enough in our world. And so trying to, this allowed us to, I think, if you go to the next slide, I want to say it was about 47 to 50 individuals participated in a variety of activities. Everything from folks like physicians and clinical providers to community members. So community health workers, pregnant individuals, doulas, and new moms. Before we ever started anything, after we got the word from HRSA, to say like, what is it like, and what do you need to be successful? What would an ideal maternal health services model look like for you here? And I think, this is one way we talk about training a lot, and we will often do language training and a variety of things around like DEI. But I think what was great about this is that we trained our staff in Comagine and in a multicultural consulting agency that we partner with to be human-centered design practitioners. And now they can take this skill set of facilitation and community involvement into other initiatives. Next slide. Okay, so moving into implementation, talked about this a little bit during our teaming phase of proposal, but we really make a big effort of trying to subcontract funds to community-based organizations as much as possible, and to work with vendors and consultants from the community and population, people who are trusted, not always putting our staff out as the conveners or the ones with a specific expertise, but bringing along a team that's really complementary and humble. And so we also focus on providing incentives and compensation for participation. Next slide. But the bread and butter of what we do is wraparound technical assistance. And while I can't talk about the initiative, like all the pieces of how we integrate health equity into all of this, or we'd be here all day, I'm going to give you a few examples of cultural tailoring that we used recently. Next slide. So again, back to our Washington COVID community-driven outreach project. As we began to work with the 14 CHWs in a cohort where we were really centering the peer and bidirectional learning, we developed together collaboratively a guidebook tailored to the Black or African American community that was really focused on what would CHWs need to know about chronic disease, specifically how it impacts within the Black community, as well as COVID and just strategies for around mental health, around really just confronting misinformation. Doing the same thing with a mental health resource now. And so really holding to, even when we're asked, can this be translated to Spanish? Can you do it for this group? Really saying what we're putting our resources into in this project in this moment was for this population, and not watering that down with universality, even though we would love to find more resources to spread and tailor this in other ways. Next slide. Another example is this workshop we created. So Taller para Promotores de la Salud. It's a workshop developed in Spanish for promotores, also known as community health workers, to learn more about the National Diabetes Prevention Program. We did this and came up with this in partnership with CDC after noticing that monolingual Spanish speakers had really high rates of diabetes and prediabetes, and were not able to connect to this program that was available to them in different communities. And so we said, who are folks connected to? Well, they're connected to promotores in their community. So we developed a curriculum in Spanish in consultation with promotores that was designed to be delivered in Spanish. And now we're working on a train the trainer and diabetes management module. And I think what is so cool to me about this is that this came about first in Spanish, first and foremost. It was not translated. It was not even transcreated. It was developed and designed by the community for the community, and just uses really unique ways of bringing people together in person to learn recruitment strategies that have really promoted retention in the program. And we've been able to do 2 pilot trainings across 5 states since we have started that. Next slide.
Joanna, I'm just giving you a time check. We'll have to wrap up here soon.
Okay. Great. So I'm going to skip over evaluation and impact. You can see our frameworks there. This slide just kind of shows, you'll notice from the map at the beginning that over this period, a lot of what resources we ended up having that CHW's connected community members to in the Washington COVID project were very similar to what the community need was stated back in the map from the survey, and really guided their approach. Next slide. I'm gonna skip over this one as well. And the last piece, just want to talk briefly about sustainability. I think you can't have any initiative without sustainability. And so good to think about collaborative business development, how to create backbone infrastructures that survive beyond the length of an initiative or project, building skills, knowledge, and resources in the groups that you're working with, leaving them with data, case studies, and other storytelling information about their own story to increase their ability to gain resources and put money back into their communities. Next slide. And I'm going to skip this one too. You can read it later, but just wanted to jump ahead then to our key learnings. So I think we're learning every day. We are making mistakes and we are correcting them, and we are gaining feedback. So listen and actively responding to the needs of community in all stages of the process. Remembering to consider unintended consequences, check assumptions. This goes for all the health equity work. And I think one thing that's become really important to me is finding intersections with existing initiatives. There's so much going on. Just even today, you heard about all the wide variety and diversity of work. And I think unintentionally, we sometimes make it hard on our partners and community members by throwing so many things. And so how do we find a way to work together, be flexible, and align our initiatives to make the work easier for folks? And embed feedback mechanisms and flexibility. Expect and go after feedback constantly. And then, of course, always doing what we can to compensate. And there's a lot of ways to do that. So thank you so much.
Thank you. In your presentation, you were highlighting the importance of moving at the speed of trust to promote health equity within your initiatives. Can you highlight how your team, one way your team works to build a trusting relationship with the community, that maybe this can be a take home for others on the call today?
Yeah, well, that's such a great question. I don't know, it's going to sound basic, but time and listening and going to where people are at. I think those are the biggest for me. So in the Washington COVID project, we had partners in this sort of Spokane area, Seattle King County area, and down in the Vancouver area. We have staff everywhere. We do a lot of our work virtually, but we made the effort multiple times to go and visit things that they were doing, like, going and hanging out for the MLK event and marching in the parade in Spokane, like being in and amongst what's happening, I think was a huge relationship builder. I think also allowing people and inviting people to share their expertise. So when we're hosting these CHW cohort meetings, it's having the CHWs be panelists, having them lead a session on something they care about, and supporting them with the skills to develop that, and recognizing that we're often a facilitator, we're often a resource bringer, but we don't have to be the experts, and we often aren't the experts. And so how to create spotlights and places for folks to shine, I think builds a lot of trust. And then I think trusting them with a resource. So like passing along 50% of those grant funds to the CBOs and doing that in a way that's easy for them to measure, creating reporting mechanisms that are that like we sought their feedback on their reporting mechanisms. Like, we know what we have to get to the state, but how can we work with you and your systems that you already have to get that in the way that's most streamlined for you and allows most of the time to be engaging with your community. So I think, yeah, it's a lot of back and forth. It's a lot of negotiation, conversation, and just really caring about what everyone is doing.
Yeah, I really appreciate that insight. Thank you. We're now going to transition to a panelist discussion. So I'm going to invite all of our speakers back and Denise from Washington Health Alliance forward, and we will move to a short panelist discussion.
Well, gosh, these were such fabulous presentations, so rich in information. Really appreciate each one of you and the work that you're doing. We have 15 minutes for Q&A, and I do want to give people an opportunity to ask questions, people in our audience. So I'm going to ask 2, and then audience members, you can submit as we're speaking. And but I'd like to start with DEI? Because it was mentioned a few times. Mike, you talked about decoupling it from health equity, right? Talked about the importance of having an inclusive workforce that, you know, Ashby, you mentioned that, Joanna, you also mentioned that, and just the work that you're doing, right, in creating educational pieces is coming from people who have been educated in this area, right, on how to connect with the patient. So I just want to briefly, to set the stage, share a little bit from a recent article that Modern Healthcare did, talking about lawsuits that are in process, right? And also some legislation. So in Florida, they have the Stop Woke Act. It bans diversity, equity, and inclusion efforts in higher education and public offices, forced health systems to alter their professional development curriculum and trainings on unconscious bias and cultural competency. Medical boards in states including Louisiana and California are facing lawsuits for physicians to study lawsuits over requirements to hire people of color and mandates for physicians to study implicit bias and health inequities as part of their continuing medical education. And Health and Human Services Department has been sued by 7 states over its allowance of anti-racism plans as eligible improvement activities for the Centers for Medicare and Medicaid Services merit-based incentive payment policy, payment system. So, like, with that in mind, right? And I think it's safe to say that we all see the important role that DEI efforts play in our ability to achieve health equity. How do we move forward in this current landscape where DEI has suddenly become a bad word?
I'll give just maybe a quick thought, Mike meant here from UW Medicine. You know, so UW Medicine is committed to be an anti-racist organization, full stop. You know, DEI is a really important part of what we do internally to us. But I do think that you point out a really important point, which is why I mentioned in my bullet points why it's important for us to separate out which end state we're trying to get to. I really appreciate Joanna and her conversation on the speed of trust, because I think that DEI and health equity is really around building that community trust by helping community members who understand better, who live in, who, you know, can understand culturally different groups, and that could be broad groups, SOGI, or, you know, racial, ethnic, or economic, or geographic. I think, and political. Let me even phrase that our country in this political divide needs to have, from a population perspective, understanding why initiatives are happening the way they are in states like Florida and others. And yet, you know, Washington State having the culture it has, and the whammy states actually having a diverse set of cultures. What we want to do is just make sure that we have clear agreement on what end goals we're trying to get. You know, if it's around making sure that health access is equitable for everybody, everyone has access to health care. By and large, we can try to make that a non-political issue that applies both in Washington State and in Idaho and in Alaska and in other states that we support through our programs. And I think that, you know, it brings out, I think, just that this is going to be a dynamic. It's not going to be static. A lot of the things that you're talking about has happened just in the last few years. I think we as a community of healthcare and health-related groups focused on improving the health of our communities really just need to be very aware, coordinated, and really just keep focus on the patients and communities by which we all serve. And I think that by staying that way and getting less about the language, less about the branding or naming the initiatives, I think that can be helpful. But it's a very politically charged time. And We just have to be very aware that sometimes when we say words, it can be very appealing for some parts of our populations that we serve, and really repelling some other folks if we say that, hey, this health equity initiative meant to help you is part of a DEI initiative. Some patients may say we're not interested in that for other reasons besides the end outcome for their and their family's health.
Thank you, Mike. Would anyone else like to add to what Mike has said? You so beautifully responded. Ashby, yes, go ahead.
Yeah, just briefly, since you called us out, just for all those listening. So CMS obviously doesn't comment on active litigation, and CMS and the Department of Health and Human Services is actively in litigation on a number of things right now. But I think what's important to remember is that as an entity, the Center for Medicare and Medicaid Services is by definition a nonpartisan arm of the federal government. We have very specific statutory authority, and there are priorities that this administration has around health equity that we are actively working to implement. And so much of the work that we are doing has truly been informed by collaboration at the local, state, and federal level to really ensure that optimal health outcomes can be achieved by all those, regardless of their status as a disadvantaged or underserved beneficiary. So with that one comment, looking forward to seeing what happens next. But I think my fellow panelist, Dr. Mint, put it extremely well. Thank you.
So, as I said earlier, a great deal shared. All of you have like beautiful body of work here. For those in attendance, what is your ask of them? Right? Yeah, what would you like to see each person take away from today and act upon?
I'll hop in really quick. This is Kayla from Community Health Plan of Washington. I think my ask is for folks to really start thinking about how we put our health equity work into accountable vehicles. So, I mentioned our strategic plan. We put it in that because it's tied to our goals. It's tied to our bonuses. There's real implications for our staff about whether or not we meet those requirements. And I encourage others to find that vehicle that works for your organization to really make it center of the conversation. Like I mentioned, we have 2 goals, one on DEI, one on health equity. Those are 2 of 8. So they get a lot of airtime for our organization. And I think it's done a really great job of accelerating our work.
Oh, sorry.
Oh, that's okay. I can just speak to, I think finding your partners and finding your people in your community. And if that feels like an area, maybe this goes back to I think it was the spark bird. I love this from the beginning from Ginny, like refining that for yourself. And I think then that leads you to how you connect to community. I think sometimes we get worried or anxious or bound up in not knowing what to do, but we don't hold that alone. I think many of us said that here today. It's literally impossible. And so sometimes for me, I think it's like when we actually simplify it a little bit more and like find our people, find where we need to make work happen together. It's amazing how fast ideas can change and concepts can change just by bringing a few people together. So I think never losing that, that core the core of relationship and the core of trust is like what's going to get us through all of this, I think. But yeah, appreciate you all.
Is there anyone that you'd like to connect with, Joanna, that you haven't, that maybe someone in attendance here could help with that? You're talking about building community.
Oh, good question. I know it's hard to know who we're talking to outside of the panelists, but I would be happy to connect with anyone that's interested. I think that's what we're always looking for is like what's happening, how can we kind of come along underneath behind, like the goal is to not be out front, right? The goal is to kind of be that facilitator. So happy to do that with all of you.
Great. Mike?
Oh, I was just going to say that, I don't think that any one group, as I mentioned earlier, can really sustain this, do this, and lateralize this across many, many groups that can be disadvantaged in different ways, in different areas, and for different conditions. And that all of us are better than any one of us. And even just hearing the discussions today amongst my panelists, my fellow panelists, knowing that people in the audience probably have another, exponential number of other initiatives. How can we do these things together? How can we study them together? And how can we sustain them together across? We have a very fragmented healthcare system, and I'll just give a quick anecdote. I was sponsoring a group engaging a community health worker in a diabetes pediatric program in a particular community. And they said, well, we may or may not be interested. And we said, what? This is, just a pure benefit. It's grant funded. And they said, well, this is the third time University of Washington has come to us. And we said, what? And what it turned out was that Children's Hospital had done one program, lasted 2 years, and then when the funding of the grant ended, their community health worker was unfunded. A second group came in the School of Nursing under the UW umbrella. And then we came in as a third entity through UW Medicine, each with different grants. And, this was a big aha moment for us at UW Medicine, understanding that the different wings, and patients don't know the different wings of UW Medicine, they just see UW, and we should be coordinated. These starts and stops can lose community trust. And I do think that the more we can think holistically in partnership and long-term, our communities get confused with CPHW versus CMS initiative versus UW Medicine versus Providence versus, and I do think that it's up to us to do a lot of the work together and start to think about, at least from a Pareto standpoint, what are those 20% of programs we can commit to in long term, make it easy from Joanna. I really like Joanna saying, make it simple for the communities to access these things and not have to choose between health systems, insurers, or other models to engage in just improving the health of them and their communities.
Great point. Thank you.
I'm looking at the time and we actually need to wrap up this event. It went so quick today. And so I just want to thank all of our speakers for joining us today and participating in the presentations and the lovely discussion. It was wonderful to have each of you. We just want to send another quick reminder that this webinar has been recorded. We will post it online. If you did sign up to attend the event, we will send out a PDF copy of the slides to those who signed up. In the chat here briefly, you will see a link to a post survey that we would love you to fill out just to provide us with feedback on your experience. We also do have a handful of events coming up that we invite you all to attend. You can see them on our screen here. I will send these out with that email as well. We also would like to invite you, which Ginny was mentioning in the start of our presentation, that the BRE Collaborative and Foundation for Healthcare Quality will be hosting a Social Need and Health Equity Summit. It is virtual from 9 to 12:15 p.m. That's really focusing on health equity. We will have a keynote speaker from from Edwin Lindo, who is fantastic, and he will be talking more about health justice. So you are all welcome to attend that. That event will also be recorded, but we invite you to sign up so you can receive more detailed information on the event. But again, we just want to finalize the event by thanking our speakers for their knowledge, time, and expertise, and they're willing to share it with all of us today. Thank you, everybody, for joining us today, and we hope you have a fantastic rest of your week. So thanks, everyone.
Thank you so much.
Thank you all.